chest.
Yeah, okay.
Thank you. One more minute. Hello, everyone. Welcome to today's first session in 2026 for the wellness team. This is our 254th session, and we would like to welcome Yvonne Liebig, PT, Doctor of Physical Therapy from our Rehab Therapy Department, who's going to discuss falls awareness and prevention, which is a much requested topic throughout the years. And we are so thankful for her for sharing her time with us, because we know that she is very, very busy. And we would like to thank also May for giving us or sharing with us the talents and resources of the Rehab Department of Contra Costa Health. And again, this is a webinar. Please post your questions on the chat and also answer our questions on the chat. And this is Arlene Trimble. If you have any questions, our email address is cchswellness@cchealth.org. Yvonne, take it away. Thank you.
Thank you very much. That was a nice introduction. Hello, everyone. My name is Yvonne Liebig. I am a doctor of physical therapy. I work here at Contra Costa Regional Medical Center. I have been with the hospital since 2013, and I've been a licensed physical therapist since 2011. I am currently one of the 3 supervisors here at the Contra Costa Wellness Center. We also offer services not only in Martinez, but in our West County facility in San Pablo and our Pittsburgh clinic. We offer not only physical therapy, we also have pelvic floor therapy, we have occupational therapists, and we have speech language pathologists, both on the inpatient and the outpatient side. By now, you understand that I'll be talking about falls and how we can prevent them. And I hope that you came because you are hoping to benefit from more knowledge on this topic, as it is extremely interesting, as it is extremely important, both to our patients and our healthcare systems. And my hope is that you will walk away having learned at least one new thing, and then feel empowered to take back control of your own life and get a rehab therapy referral so you can come work with us soon. My objectives are quite simple. We're going to talk about the reasons for falls and how you can decrease your risk. So when we start to talk about falls, I want you to think about the first thing you picture when you've tripped in the past. Is it your life flashing before your eyes? Because unless you're someone like Jackie Chan or Calvin here, chances are your fall was unplanned, took you by surprise, and you're not typically able to do this quick, fancy tuck and roll. Although it would be really nice to come out of it with a ta-da instead of a bloody knee. We most likely are going to put our hands out to brace ourselves if we're going to the front or the side. And if we slip to the back, we're going to fall on our butts or our backs. Most of the time, we are bracing for impact and trying to protect our heads. Our heads are the most important part of our body. But falls happen, and they happen for all kinds of reasons across all ages. Kids fall all the time, but they're more likely to fall because they play. They rough and tumble, they're in sports, they slip. It's mechanical. But when we're young, we heal pretty quickly. That's the magical power of being a kid. As we get older, we fall for many more reasons, and the risk of injury goes up. I can tell my patients all the time, the older you get, the harder the ground is. And the reason this is so important is it is the leading cause for injuries among older individuals. Older individuals are generally seen in the population as being 65 years or older. It is costing the healthcare system over $80 billion a year, and it's going up. It's been going up pretty steadily since 2020. It's estimated that at least 14 million people fall each year. That's 1 in 4. So if that's not you, then it is somebody that you know, somebody that is close to you has taken a fall. And these injuries can be debilitating, and for good reason. They can lead to fear of falling, which will then affect your quality of life. We'll take a look at the diagram that shows very well why it decreases the quality of your life. Say you have fallen. There's a fear, a very healthy fear of falling. So you decide, well, I'm not going to go for walks anymore. I'm too afraid, or I'm not going to go up those stairs. So then you're not being as physically active, which leads to weakness, decreased balance. And then that will actually increase your risk of falling, and the cycle occurs again and again. It's not just about having bad balance or being born with bad balance. It's multifactorial. So there are some very common reasons for falling. Poor vision. As we age, our vision changes. Poor lighting. We have dark rooms. We have shadows that may play tricks on our poor vision. Neuropathy, or a decrease in sensation in our feet and our legs. This happens because of different medications. It can happen because of diabetes. Decreased sensation can also happen because of vascular deficiencies. The blood flow to our legs and feet can change as we age. Incontinence. We don't want to have an accident, so we're going to get up and we're going to rush to that bathroom. That can lead to an increased rate of tripping. Pain. Pain can cause falling. Abnormal joint mobilities. This can be too much movement, can be too little. If we consider an ankle, you turn your ankle and you fracture it and you end up with surgery and they have to put plates and bolts in your ankle, then it's going to be pretty stiff versus that ankle that didn't break but tore a lot of the soft tissue. Well, now it's going to be unstable and it's going to move too much, which leaves you open to rolling it again and again. Obstacles. I can't tell you how many times people come in and say, my dog ran in front of me. That happens. We can't plan for that, but we try to be as careful as we can. It could be a toy on the ground or an extra shoe you didn't see, a throw rug. Various dizziness. Dizziness is very disconcerting. It can throw you off in space and you fall over. Footwear. People are wearing very easy slip-on shoes these days, and some of them are not the best to reduce fall risk. Foot hygiene. This is a lesser known topic where if you visit your podiatrist, we need to take care of those very painful thickened nails, thick painful calluses, and other skin conditions that can afflict our feet and make us less likely to want to walk or unable to walk normally. Of course, weakness. As we age, we do tend to get weaker if we are not training. And decreased balance, absolutely. So let's talk about how we can decrease some of that risk. That was a lot of common reasons, but there are things that we can do. Get regular vision checks. See your optometrist and your ophthalmologist. Make sure you take care of your eyes. Make sure you're wearing the right prescription glasses. Night lights, especially when you have to get up and go to the bathroom in the middle of the night. Night lights are great. Maybe brighter lights in the house. There are different kinds of light bulbs that we can use and brighten up spaces that might be a bit shadowy. Remove all appropriate obstacles. We might not be able to remove the cat or the dog, but we can certainly remove open cords, throw rugs, have your kids put the toys away. Absolutely focus on wearing stable shoes. Visit your medical management team. Our health is ever changing. If you have symptoms that are new or getting worse, it's time to visit your doctor or your specialist. Have your medications looked at, talk to them, see what can be done. Don't wait because you think, oh, I'm just getting old and this is what I have to deal with. That's not the case at all. And of course, me, come see my department. So let's talk about how physical therapy can help you. There are many, many ways, and I'm going to touch on the few that are going to help you decrease your fall risk specifically. But first, before we move through anything else, please, please take a look at this list of unsafe footwear. Do not go to your doctor's appointments in any of these shoes if you can help it. Oftentimes, all of these clinics, they have the linoleum or the shiny tile floors. They're already slippery. So you put that floor with these kind of shoes that have smooth soles or they just slip on, you're more likely to fall at the doctor's office than you are in your home, and we don't want that. So try to wear shoes that are more supportive, and we'll look at that list next. But in PT, we want to be active. We want to move around. So you can't come wearing these shoes and expect that we can operate safely. We'll have to stop the appointment until next time. So avoid heels, avoid platforms. You might look at that and think, well, that's got a thick rubber sole, that might be safe. But it is so thick and often then so stiff that your foot won't feel the ground as well as it should. And perhaps you'll step on a crack in the sidewalk, not notice it, and then you'll be off balance, maybe twisting that ankle, maybe suffering from a full fall. Proper shoes, however, shoes with laces, shoes with straps that go over the top of your foot, shoes that have a good flexible rubber sole, low to flat, something that fits well. You don't want something too big that's loose and floppy. These are great shoes. These are stable shoes that will help you be safer in the world. Sometimes we also recommend a safe house shoe, especially for those who have certain foot pains like plantar fasciitis or bunions, or they're sensitive to cold. Having a good house shoe versus a little slip-on slidey slipper is also a good bet. Pain. Pain is probably the most likely to be associated with physical therapy. I'm sure many people have gotten referrals because they have some kind of pain. Pain can act like an off switch. It's not just that we're suffering pain, but if you were to take a step and you get a sharp, sharp pain in the knee can give out. The muscles turn off, you go down, you fall. What's happening is your brain is automatically thinking, oh my gosh, that hurts, that's dangerous, I shouldn't be doing it, turn off, protect myself, don't do the thing, and you suffer a fall. And while that's effective early in an injury, if it goes on and on and on, it is now no longer serving its purpose. And if we were cavemen, then you get eaten by the dinosaur. So you come to PT and we provide you with certain pain education that teaches you about pain. We get to teach you about what's really bad pain we need to respect, we need to stay away from, and other pain that is not indicating further injury. We learn how to work through it through things such as this diaphragmatic breathing. Breathing has a tremendous effect on how we manage pain and how we manage stress and how we can sort of flip our nervous system to relax, that rest and digest instead of the fight or flight. We may have a stiff joint. Stiff joints can be painful, so we do some joint mobilization either through exercise or with our hands. We help to lubricate that joint and it's no longer as stiff, no longer as painful. Of course, then if we have something that's too unstable, that ankle that has all the ligaments torn, we're going to strengthen. We're going to protect that joint. Maybe we provide an ankle brace for a little while. And then, of course, the stretching of the stiff muscles, the strengthening of the weak muscles. All of this is put together and helps the body support itself, leading to less and less pain over time. Strength training. I would love for everyone to take a second and scan through this graphic because all of the benefits of strength training and all of the rest of my presentation are represented here. Research after research and meta-analysis and clinical trials have proven time and time again that strength training benefits us as a whole. It can increase your gait speed, how fast you can walk from 4 to 50%, depending on the article. The faster and more safe we can walk, the less likely we are to fall. Bone density. In older individuals, we're more likely to see decreases in bone density, osteopenia or osteoporosis. So those who should fall suffer those dreaded hip fractures. Or if their bones are thin enough, their hip will have fractured first, and that causes them to fall. But if we are doing strength training, these muscles are pulling on our bones. And that's telling our brain that we need to fortify those bones, make them stronger, lay down more calcium, allow our body to do this and accept this work. So that way, should you fall, your risk of serious injury goes down. Posture control. I'm sure some of you have gone to the mall on the weekend and maybe seen the ladies or the little men who are they're stooping over. Gravity is kind of winning as we age. That's not okay. That's going to throw them off their balance. It's going to change their base of support. But with strength, we can support the spine. We can support the joints. We want people to be upright, where their vision can see the horizon, where they feel more stable on their feet. It decreases their sway. It increases their stability. It makes them safer. And of course, strength training increases our muscle quality. As we age, we change at a cellular level. It is going to happen to some degree. It is not something that science can change yet. Our muscle fibers shrink, so our muscle quality decreases. But if we strength train, we can increase our strength by 15 to 35% just after 8 to 12 weeks of resistance training. So if you're willing to put in the time and effort, you're getting great gains in a relatively short amount of time. And even though someone who's 70 and has never worked out before and thinks, okay, well, I'm going to try, you can absolutely make positive change in your body. You didn't have to work out all your life. You might not look like someone who's 20, but you can positively improve the quality of your muscles, how strong they are and how they work for you. And that might be the difference of getting up out of the chair all by yourself versus needing someone or something to help you. You can be independent. Strength training has a positive influence on our balance. In combination with a balance training program, which in and of itself is also a strength training because you have so many muscles involved in helping you to balance. So it's a very complementary system. And our coordination. When we are strength training, we're lifting weights, maybe together, maybe one arm separately, maybe we're doing lunges. So our feet are apart. We increase our coordination because of these different new activities. We have to learn how to do them the right way. And this improved our timed up and go. So what that means is how strong were somebody's legs to get up from the chair and initiate the first step versus struggling to get up out of a chair, struggling to move the leg forward, and perhaps catching a toe on the floor. So the important takeaway from this slide is to see at the bottom that strength training reduces risks of falls and injuries by up to 58%. I mean, it's better than 50-50. If all you have to do is get stronger, it's a great way to go. It's not medication and it's good for your body. And you have control to take back your quality of life. So then let's go on to balance. Balance is complicated. There are many, many systems involved in proper input and output and preventing yourself from falling down. So this first graphic here is called proprioception. So this is how does your brain and body know where you are in space? We have a lot of receptors in our body that communicate with our central system, our central computer, which is our nerves, our brain, our spinal cord. Muscles detect stretch. For instance, you go to step on a curb, you slightly miss it, your heel slides down. Well, your muscles are going to tell you, oh my gosh, my calf is being stretched really fast. The sensory feedback, if all of a sudden you were walking fast and you hit that curb, it was windy, but the wind stopped. You know you have stopped. Your skin tells you that. or if it's too hot outside, it's too cold. Your joints have receptors that tells you position. Am I bending over? Am I bending my elbow? Am I straightening my elbow to put the milk on the counter? And the tendons. Tendons are the tissues that are attaching those muscles to your bones, and they're going to tell you how hard something is. How much force are you producing to lift something or to brace yourself? And all of these get processed in our brain instantaneously to affect your reaction time. If you catch a toe, if you trip, how fast can you react to stop yourself from actually hitting the ground? Or what can you do to put your arms out fast enough to block from hitting your head or your face? And then are you able to multitask? So you are assimilating all of this feedback all at once, all of the time, every day, to do more than one thing at a time. We are rarely doing one thing at a time. We have our ears on, we are listening to something, we're looking across the street to make sure we don't get hit by a car while we are also walking. We're catching more and more people on their phones, looking down, scrolling, answering emails as they are walking. It's a beautiful thing, multitasking, but we need to be able to do it safely and well. So initially, when I ask patients what they think their balance is, what do you think they think? Because I'm going to tell you 9 out of 10 are going to say, oh, I can't stand on one leg. Everyone thinks about static balance, standing still, standing on one leg. And while this is important, it's not the only piece of balance. But I did include a graph because there are normative values. We've done a lot of research and taken averages across males and females through the lifespan. And we've come up after 3 tries for each person, averages. So for instance, let's take a look at the male-female group for the first age range, 18 to 39. It's right around 45 seconds. But as we get older, if this is not practiced, if you are lucky enough to make it up into your 80s and 90s, this goes down to about 8 to 10 seconds. Now, if we remove your vision and do it with eyes closed, even the younger age group goes from 45 seconds down to an average of 13 to 16 seconds. But remember the strength training. We can change this. We can practice this. You can make it better. So in addition to the static or the standing still is the dynamic balance, the ability to stay upright while you're moving or the walking. And so researchers have done a 6-minute walk test. This is done in our clinics all the time because your walking speed is directly correlated with quality of life and safety. So if you look at the very fastest speed here, 3.4 miles per hour or higher, this is kind of a medium to brisk walking speed, depending on how little or long your legs are, I suppose. This is your best longevity, your best quality of life. You can pretty much get from here to there safely the way you need to. And our next blue category, about 3 miles per hour, this is about average on what we walk on our day-to-day basis, still safe, okay? We can even enter into the green category. This is the minimum speed it takes for people to safely get across the street. So that's where they kind of base this time frame on, is they've measured time and time again the average length of the street and the average length of time it takes people to get across the street before the light turns again. Again, still less likely to fall. But now we start getting into the lower ranges, and the rate of our speed decreases in addition to the increased rate of falls or the increased risk of falls. People tend to need more assistance, whether it's from another human being or an assistive device. But strengthening can improve both of these. Both of these items were included on the strength training graphic. So there is hope. Sometimes, regardless of what we're doing, we still need assistive devices For various reasons, through the lifespan, things happen. And I cannot tell you how many times we see patients coming in with ill-fitted assistive devices. They're no longer assistive to you. They're a hindrance to you. They're dangerous. They can increase your fall risk. They can add to injuries by giving you another one. When people come in with crutches, so often we see them all the way up in their armpits and they're sort of leaning on them. It's too high. In this diagram, you'll see there should at least be 2 to 3 finger spaces between your armpit and the top of the crutch. All of your weight and movement should actually be just through your hands. That way, there's no pressure to those precious nerves and blood vessels up in your armpits. Similarly, we have patients come in who need walkers, and walkers are great. They provide extra stability for those who need it. However, we see them too high, in which case they're leaning back, the patients are leaning back, and it's leading to sort of an unstable backwards base of support. Or they're too short, which is causing this patient to lean forward, putting too much weight on their hands. Often they might be walking behind that walker, and then they're arching their back too much. They're slumping or they're bending, and that's going to increase the pressures on the spine, which could often lead to more back pain when they didn't have it in the first place. And then lastly, of course, canes. Canes are great. They're used in one hand, but they also need to be measured. They need to be the correct size based on your height. We see them too tall, then they're not helping you at all. They're just sort of there for looks and for comfort. Or they're too short and someone is leaning onto them. And often, believe it or not, people use it on the wrong side of the body. The canes typically should not be used on the same side of the leg that's injured, unless for some reason the other hand or wrist or elbow is injured in some way and can't tolerate the weight of the cane. But the cane should be on the opposite side of the body of where you have your injury, because this allows you to be even and upright. And when you walk, I want you to remember that you swing your arms opposite to the legs. So when your left arm is forward, it's with your right leg. So that's where your cane should be. You want the cane on the ground at the same time as that foot, because then your base of support is even. If you put it on the right hand, then you're putting your right arm forward with the right leg, and that's making you lean unnaturally to that side, making you at a greater risk for being off balance and possibly falling down. It's not natural to your body. So when I teach people with canes, I put it in the correct hand and I tell them just walk. And I see what they can do after a little while, because more often than not, they organize it all by themselves. If I start talking too much, they get super confused and very frustrated, and I don't want that at all. Now, dizziness. We get a fair number of patients who are referred to physical therapy for various dizziness diagnoses, but there are 2 that we can treat. The first, most common, you will hear it called vertigo or BPPV, and that is broken down to benign, paroxysmal, positional vertigo. You feel like the room is spinning. You turn your head to the right, or you roll over in bed to the right, and all of a sudden the room is spinning and you throw yourself backwards or sideways. Dizziness is scary. It is not normal unless you're a child spinning around, okay? Then we're doing it to ourselves on purpose. You predict it. But when it starts happening to you spontaneously, it creates fear. It's very disconcerting. So in the BPPV photo, I've shown you a picture here of the deep inner ear organs. There are 3 big canals in there, okay? Well, small by comparison, but 3 canals that all contain fluid and hairs. This fluid and these little hairs are telling your brain where you are in space. There's 3 of them because we live in a 3-dimensional world. Occasionally, there will be a little crystal called an otoconia that gets caught in one of those canals. So when you move your head to the right, that little crystal decides it's going to move, moving that fluid and moving those hairs, giving your brain the impression that you're spinning much faster than you ever were. And then you feel this whole sensation of dizziness. The world is moving, even though you only turned your head or you only rolled over in bed. So patients come to physical therapy when they can't get out of it on their own, and we send you through a series of movements that helps to move the crystals through and out of those canals to flush them out and to give you the restoration of normal movement. A lot of times this happens spontaneously. You don't need a physical therapist to put you through this series of movements. But occasionally, one of those little crystals will get stuck and kind of go back and forth, and it can't find its way out of the maze. And that's when we can certainly help get you through it. The second form of dizziness that we can help with is called oculomotor dysfunction. Oculo means eyes. Motor is the movement. This happens a lot with head trauma, especially concussion. So if you end up with some kind of brain trauma, the eye reflexes, how your eyes move in relation to your head, becomes disorganized. So now your eyes are moving irregularly, which is giving your brain abnormal input. It's telling you that you're not quite moving right, and it gives you this ambiguous feeling of dizziness or wooziness. You might feel that your eyes get extra tired, more so than before. It feels uncomfortable, but you're not quite sure how to explain it. But if you know you've had a head trauma or concussion, maybe a motor vehicle accident with airbag deployment, this could be part of your post-concussion syndrome. And physical therapists can take you through a series of eye exercises to help restore normal strength, normal coordination, normal movement, and decrease that sense of dizziness and wooziness. Incontinence. This topic is extremely important. It should be addressed, and it shouldn't be embarrassing. I've heard so many patients say, you know, I stopped going out to dinner with my family, or I don't go to family functions anymore. I'm too embarrassed. I have to go to the bathroom all the time. Or I'm afraid I won't even make it to the restaurant before we have to pull over, or I might wet myself, or you know, I'm looking for bathrooms every place I go. I have to see it, I have to know where it is just in case. I mean, that's not a great quality of life, especially when we can do something about it. But not everyone knows that there are pelvic floor specialists. As we age, weakness it's not going to discriminate. Weakness can happen to all our muscles. And our pelvic floor is our base. It's our foundation. It supports our organs. It supports our lower back. It's really important, not just for the purposes of not having an accident, although that's a very important and very real goal about pelvic floor physical therapy. And how it plays a role in falls, of course, nobody wants to have an accident. Nobody wants to have the embarrassment. So they're going to feel the urge to go. They're going to get up. They're going to rush as fast as they can to get to the bathroom. And that's where everything else exits your vision. You may not see the cat lying on the floor. You're just trying to get to the bathroom. Or you get up in the middle of the night. Maybe it's dark. There's no night lights in your room. You're rushing. You trip over a shirt that was left on the floor, right? But we can help. We can absolutely work on strengthening the pelvic floor. So you are less likely to have urge, you're less likely to have accidents, you are less likely to have to rush to the bathroom, and you can re-engage with those family functions. You won't be afraid to go on long drives that you once loved, looking at the countryside on the weekends. You can get back to the things that you enjoy doing without fear. And I also, before I leave this slide, I want to make sure that people know that incontinence as we age might be common, but it isn't normal. You can manage it. There is absolutely stuff that we can do to help you through. Neurological disorders. This is my last big topic for what causes falls in our patient population. Neurological disorders are those that affect our brain and our nerves. The most common causes in our patient population come from stroke, which of course is a direct injury to the brain, which is our central computer system controlling how we move through the world. Head injuries, such as concussion, such as car accidents, any kind of head trauma. Parkinson's disease. Parkinson's disease is something that attacks the cells in the brain responsible for creating a neurotransmitter called dopamine. Dopamine is a chemical that helps to control body movement. And that is why the less dopamine we have for Parkinson's patients, the more of the sort of tremor you start to see. They can't control it. Multiple sclerosis. This disease attacks the lining of your nerves. So I like to think of the nerves like a wire. You've got the copper fibers in the center where the electricity is delivered, and then you have the colorful plastic coating on the outside. That coating or insulation helps that electricity to get from point A to point B as fast as possible. But in multiple sclerosis, your body starts to eat away at that colored plastic. So now you're getting electricity that can exit the nerve long before it reaches its target. So now you're having maybe a little bit of shooting pains in certain areas, and then you're having less strong activation because you didn't get as much of the electricity to the target muscle as was intended. It's exiting too soon. And a lesser known disorder is called myasthenia gravis. We don't see it as much, but I did feel like it was worth mentioning because it does happen. This is an autoimmune disease where your body is attacking itself and it's affecting how your muscles respond to the nerves. So a little bit of an opposite direction of the multiple sclerosis. All of these types of disorders have similar results. We end up with muscle weaknesses, abnormal tone. What this means is your muscles can become too stiff. They don't know how to respond to the electricity and they just sort of lock up versus becoming flaccid. Flaccidity means that there is no input to the muscle. There is no contraction. You are telling it to work and it's doing nothing. The communication is lost. We have poor motor planning. You know, I can't think of like, how do I get my foot on this step? Certain strokes or brain injuries really block this whole idea of how my brain is communicating to my body, and it just sort of gets cut off. And of course, like Parkinson's disease, we have that decreased movement control, the tremors, the fasciculations where your muscles are sort of twitching. You don't necessarily have a conscious control of that movement. It's happening without your involvement. And all of these result in an increased fall risk. But rehab, our different therapies can help. And this is where I want to take a moment and I want to pull off my physical therapy hat and I want to give a shout out to our occupational therapists and our speech language pathologists. Because while you might think that they would not be as involved in fall rehab, fall recovery, fall prevention, they most certainly are part of our team. Grip strength, for instance, has been demonstrated to have strong correlation to falls. And this could be for a multitude of reasons, but just to name a couple, if you are going up or down stairs, you should be holding onto a rail. But if you don't have strong hands, you might not be able to hold onto that railing as strongly as you would need to, okay? Or if you're using that cane or that walker, perhaps you have one hand that's stronger than the other, that leaves you a bit off balance. You're not equal. Now, our speech language pathologists, they're a little bit more involved, and I have learned much about their profession the longer I've been here and work with them, because they're not only involved in our language processes, as their name says, speech and language pathology, but they're involved in how we articulate our words. what our voice sounds like. In some of these neurological disorders, our voices get smaller and smaller. So even if someone wanted to yell for help, we might not hear them. They're involved in controlling our fluency, how well we can enunciate our words. They help us with word finding. Brain trauma can do very interesting things to our speech and language centers. They have memory problems, problem-solving problems, where, you know, if someone is suffering from something such as dementia, they don't remember where they are. They don't remember where they're going. They might not remember to look at the curb or remember that they need to turn left. This makes them a fall risk. They just innately become less safe than they once were, and it's not their fault. Their brain just isn't working normally anymore. And then often when we have problem-solving issues, we are more impulsive. And the more impulsive we are, the less we think about the things we do. We are going to move too fast. We're not going to clear that step. We're not going to lift our leg high enough to get over the dog, and we fall. Okay. So all of our disciplines, we work together. We're holistic. We can help put your whole entire body back together to increase your quality of life, right? And of course, I'm going to pull back to physical therapy and remind you that we work on strength. We work on balance, we'll stretch you. We improve the proprioception, energy conservation. That's something that's not touched on a whole lot with patients. When you have a disorder, when you have a surgery or a fracture you're recovering from, you have to learn how to move your body again. And during this time, it is effortful. Patients tell me all of the time, I never knew that I would be this tired learning how to walk again. Absolutely, because it's not innate anymore. It's not reflexive. When we learn to walk, I bet you never think about walking outside anymore. You just do it. It's just natural. But you don't know anymore how many pieces of your body are giving you input to stay upright, to move a certain speed, to move fast, to turn your head right, miss that car, move away from the bee hitting you in the eye. I mean, you're constantly changing and adjusting to keep yourself upright. It just became a reflex to you. But when that is taken away because your nerves aren't working or because part of your brain isn't working and you're not getting all of that feedback, we have to retrain everything, and it takes a long time. So therefore, you are much tired. You do have to learn how to take it in little bits so that you don't end up exhausted. We teach you how to walk. We teach you how to plan. How are you going to navigate those stairs? How are you going to get from here to Miller Wellness Center safely? And our reaction time. If you were to trip, how quickly can you block yourself from falling and hitting the ground? But falls happen. So while I know that in the presentation description today, they said that there would be a fall demonstrated, but I'm going to pull back on that promise. Falls happen. And as a runner, I myself am familiar with the ground. I have a story that when my husband and I first got married, we moved to San Francisco and I was in PT school. We both were avid runners. We ran cross country and track competitively. And so around San Francisco, there are a lot of trails, and we gave each trail names for various reasons. And one of them was so aptly named Fall Trail, because for whatever reason, I could not stay on my own feet. So I had fallen about the same place too many times to announce. It's embarrassing. But in addition to that, I've slipped on ice. I've slipped in the mud. I've hit far too many cracks in the sidewalk. I am familiar with how hard concrete can be, that's for sure. So instead of me demonstrating, I included a couple photos here and descriptions on how to recover from a fall to the ground. In some of my rehab therapy sessions, I will never ask someone to actively fall. However, if I have someone who has Parkinson's disease, or I have a patient who has had a stroke and left them weakened on one side of the body, At some point in our treatment series, I will work with them to get onto the floor. I do this for a few reasons. Number one, I don't want them to be afraid. If you have a plan, it removes some of the fear. I tell my daughter, don't be afraid of math. Don't hate math. Just practice it more. Take away the fear. Take away the frustration. So if I can get my patients' trust and I get them to the ground, we practice. How are we going to get up? Because then if it ever happens, they're going to go straight to that thought, I need to get to my stomach. I need to get to my hands and my knees. And if I can use my own knee, I'm going to stand up. Or if I need to crawl to a chair, that's what I'm going to do. And that's a bit of what this first picture shows. While he still used his own body strength to get up from tall kneeling, if he were to stay in that hands and knees style and felt like he could not get himself up, he was injured, he was too tired, too weak, he could potentially crawl to a stable chair, stable sofa. And once he gains a little bit of strength back, he could help himself up to sitting. Okay. If you go down in that picture and say you hurt a wrist, all right, and you wouldn't feel comfortable crawling like that, you could stay on your forearms and elbows and kind of do an army crawl, still getting yourself to a place where you could get up and sit in something more comfortable. There's no reason you should stay on the floor for hours ever. Okay, it's not safe down there. It's cold down there. But if for some reason you are alone, you are older, and you are still fearful of falling, I encourage patients to get a life alert necklace, the button that you can push should something happen. That way you will get emergency medical services to your door, or a whistle. Maybe you live in a larger house, and perhaps you have family or neighbors upstairs, you live downstairs, something were to happen, you could whistle for help, or keep your cell phone with you. Good pockets, always keep your cell phone. If something should happen, call for help. So in this presentation, I hope that people learned that together we can decrease the rate of falls annually. We can decrease the severity of injuries. And if you're super motivated now, I've included a multitude of links for more resources in the communities, more answers to questions that I may have now provoked. But I highly encourage you at some point to go see your doctor. I hope that this presentation has kind of had you think, oh my gosh, you know, that's me, or oh my goodness, that's like my dad. See your primary care provider, get a referral, come to rehab where we can see where you are, see what functional limitations you have, and build a customized, functional, safe program in all of its pieces and all of its components, because a whole human being is a lot of systems to look at. And while I encourage you to start on your own independently, it's helpful to have our professional eyes on you so we can get you what you need more quickly, more safely, and give you back quality of life. That concludes my presentation. Thank you so much. I hope you learned at least one thing today. Come see us in rehab. And now I would love to take questions.
Thank you so much, Yvonne, for your time. We have a question. The first question, you said to avoid platform shoes, but what about the walking tennis shoes that are made with thick cushion for walking support, like the Hoka's, New Balance, Skechers, Nike, etc.? Are those okay to wear?
Yes, because their soles are made for walking or running, so they are soft, and you come into contact with the ground, you can feel it better. They will move. They're flexible. The platform shoes I was mentioning are the very thick, very firm rubber that does not flex well.
Thank you. The next question is, I might have missed this, but how many steps do you recommend an adult, the age range from 45 to 55 years, walk daily, or even an average person, how many steps do you recommend to have completed in a day?
So I didn't mention anything about average steps, though I know the standard before was 10,000 steps a day. I have also heard recently that that number has changed, but I have not done recent research to give you an actual number that may be accurate at this point.
Okay, thank you. And we have also another question. Can you please restate which hand should be holding the cane when walking?
Yes, it is the opposite hand of the leg that is injured. So if your right leg is injured, the cane should be in your right hand, your left hand. If your left leg is injured, the cane should be in your right hand.
Thank you. Do we have any additional questions? Please post it quickly on the chat. And we have a lot of kudos. Great presentation. Thanks, Yvonne. And this was a great presentation. Thank you.
Thank you so much for having me. I hope to see people in rehab.
Yes. So everyone, thank you so much for staying with us. And Yvonne, thank you for celebrating our first session for the year with a very, very important topic that is very much requested.
Thank you very much.
And everyone, please complete the evaluation. I have posted the link on the chat. And as promised, we will send you a copy of the presentation this week, together with the link for our YouTube channel, which has a recording. Please feel free to share with your colleagues, friends, family, and community members. If you have any questions or suggestions, please send it directly to cchswellness@cchealth.org. Thank you, everyone. And again, the link is on the chat for the evaluation. Quick question from our phone participant. If injured recently, would you recommend PT referral?
Yes. We can help with new recent injuries as well as long-term pain.
Okay. Thank you so much, Yvonne, for your time. And thank you, everyone. I will send you a copy of the evaluation, and I'm sure they will be all glowing and positive.
Thank you so much. Okay. Thank you for inviting me, Arlene.
Okay, take care. Have a great year. Bye, everyone. Please make sure to enter or to complete the evaluation. This will really help us in planning our next event. And just reminding you that tomorrow at 12:05, we are going to do another session for 30 minutes from rest